right. Welcome to another edition of our podcast. Renee, where are you at today?
I'm sitting in Phoenix and we're always a few weeks off on our recording. And let me just tell you, it's already over 100 degrees now, with weeks and weeks. And I think they told me yesterday they're in a 30-year drought. And so, wow, it's pretty toasty right here, but that's where I'm sitting in today. But you're somewhere else too. You're not home. So where are you?
I'm in Grand Forks, North Dakota. We couldn't be farther apart. We're almost completely splitting the north and
Oh,
south parts of the country here. Yeah, I almost drove through rain. It was lightning the whole west,
wow.
looking to the west as I drove up from Fargo last night to Grand Forks from the airport. So, yeah.
Yep. And so those of us listening out there, we do rural. And you may think, well, Phoenix doesn't sound so rural, but let me tell you what, my conference that we're going to talk about today is in Flagstaff, which is 2+ hours north of Phoenix. And that's if the traffic cooperates. That
Right.
was the wildest ride. Well, we should just talk about the wildest ride I've ever done. First of all, just like when I lived in New Mexico, you could basically go as fast as you want. And if you go slower than the posted speed limit, you might get run over because people are not messing around. So you have to find your groove. And then because there's so many curves and turns in the mountains, it's like driving those little video games, to be fair. It was kind of fun. And also kind of scary depending upon which parts of the road you were on. So kind of a wild beginning of my week. So, everybody, today we're going to talk about the Arizona Rural Health Conference. And last year, Brent and Jason did this conference. This year, because they are in Colorado first and now in North Dakota, I got to go to Arizona and do the conference, which is really fun for me because I don't do these as often as they do. But got to get out and go meet some people and talk rural. And by golly, they all came from everywhere in Arizona. So I met a lot of rural folks. It was a lot of fun. So today we're going to kind of do a rundown of the conference, what we learned, some of the things we're talking about at the national level that applies to all of us. And then one of our favorite topics we do very often, acronym soup. I literally sat through this conference and did not actually figure out what some of the acronyms were by the time I was done. So I always try. I always try to, it's almost like a bingo game for me. I try to write them all down as they say them and see if I can figure it out by how they're talking. No, no, they are the kings and queens of acronyms, I believe, out here in Arizona. And I think we talked about this probably the last time we did the Arizona one. So, Jason, kick us off. What's happening on the farm while you're in North Dakota?
Well, it actually started when I was in Colorado earlier in the week.
Hmm.
And I fixed the sprayer pump. Actually, Zane and I fixed the sprayer pump and we didn't have a chance to test it. I got a video from my brother-in-law of water shooting everywhere outside of the pump. So clearly I don't know how to rebuild a sprayer pump, Renee. And so I should be home probably fixing that, but here I am. But you know what else? I'm good at breaking things on the road. I don't know if you know this or not, but I had a rental car a couple weeks ago, and apparently I returned it with a scratch on the rim. And
Oh,
so I now own a BMW rim that I've given the auto rental company. That's very nice. And then I don't know
oh,
if you know this or not, but we were jeeping through Colorado, probably an area we shouldn't have been with a rental car, and we blew a tire
no.
out on I would call it a gravel road. It was more of a rock trail. So I'm not,
Did you
we're not,
did you have a spare at
we
least?
did have a spare. We were able to change the tire before dark and get out of where we shouldn't have been in the first place. But it was quite the adventure, let me just tell you.
Yeah, and everybody, there's another story when they drove to Illinois for work and ended up with a dump truck. I'm telling you guys, these two
That's
on
true.
these work trips are just getting weirder all the
It's
time.
true.
So
We'll have to tell the dump truck story. Let's let that hang there. Then
we'll
how did
let
we
it
end up
hang. We'll do that
driving
as a
home
closing story
in a
another time.
dump truck? Yep,
Well,
that's it.
today, everybody, I was supposed to be speaking at the Arizona Rural Health Conference, and I really love doing that because I get to meet lots of great people, but I also get to learn what's going on in rural around the country. And a lot of folks are talking about House Resolution 1, which is the big Medicaid cut bill and work requirements and all the things that came out of that bill from last year. And the implementation is ramping up. And there's a lot of conversation about rules getting written for pieces of it. And a lot of folks in Arizona are really advocating to get more money. It sounds like that they got the standard allotment the first round, but the second round they did not get what they believe that they should have, and they're really going to be struggling. And so a lot of the mood was pretty dour and sour from the beginning of the conference. And so then by the time I spoke, I had to put a little pep in our step because that was right after lunch. They served pasta. I thought for sure everybody was going to fall asleep. So I had to like
Yeah.
give a little extra energy because I was like, okay, it's been sort of a doom and gloom scenario. And we all still have to do the work, right? Even in this situation. So we're trying to, how do we do good things? So we were talking about collaborations and in a environment like this, when you don't have a lot of money, collaboration is key. The days are past when every hospital could just start up their own whatever program when they needed it. They could hire their own therapist. They could do their own outpatient clinic. They could do their own substance use. They could do their own. You can't anymore. And the people in the small communities that are doing all three different groups doing the exact same thing, we're not there anymore. So today is the day of collaboration, and that was our message. So I'm really excited to talk a little bit about that. But let's talk about some of the other stuff we talked about. So you went to this conference last year and you guys found it pretty
Yep.
productive. What did you like about the conference? Why did we go back? Why did we do this again?
Well, we thought it was a really valuable conference. I think they are doing some really innovative things in parts of
Hmm.
Arizona. It's funny when I hear you talking, though. We were in Texas last year, and it was the same conversation in Texas last year. Like they were looking ahead. They knew the consequences of Build Back Better, and they were pretty open about how much money they were going to be losing into the system, right? Because we're just shifting dollars. We're shifting dollars for this 5-year payout of decreasing the number of folks who have Medicaid, which folks who have Medicaid are still going to go to the hospital. They're still going to need behavioral health services. And there's just going to be no mechanism to pay for them. And that loss is far greater than what these measly dollars that are being injected into the system for one time things really are, right? Because that's all Build Back Better is one time funds that are going to fund some things. But at the end of 5 years, it's going to be dire for everyone. And so it's good that Arizona is recognizing that. But going back and begging for a few dollars right now doesn't fix the long term problem that we're really facing, right?
No,
And so it always intrigues me to go to these conferences when that takes all the light and takes away from what should we be doing to provide better care. And I think those parts of the conference were much richer there. Kind of seems like they got bogged down in the minutia of all the things happening this time, and that can be good. We need to pay attention to it, but really uncontrollable for all the providers that are there, public health, hospital CEOs. It's out of their control, and so that doesn't mean we should advocate for it, but what should we be doing to prepare and get lean, like you talked about, collaborate? Where is it we have to start cutting the fat out of the system?
right. Yeah, so they were really talking about, I mean, it was getting down to the nitty gritty, and I won't remember all the details, but they were talking about how many thousands of jobs are going to be lost. They're
Mhm.
starting to talk about, how many people getting moved off of that expansion group of
Yep.
Medicaid adults. And those are the ones that are being targeted. Because if anybody doesn't
Mhm.
recall, expansion happened during COVID, and we've added a lot of extra people to the Medicaid rolls that didn't used to qualify. So for big picture, what they're trying to do is roll that back now that people were on it that didn't used to qualify, trying to get them back, put the Pandora back in the box, which
Mhm.
doesn't really work, but that's what we're trying to do here.
Right.
So they've got this idea, and the federal government, it's not sustainable financially. We have one of the highest costs of healthcare in the world. And
Mhm.
so there's a lot of things now. Is this the piece they should be working on to fix that? That's the big fight, right? It's like,
Right.
yes, it costs too much, but is this what costs too much? And I don't know the answer, but it was really hard to hear all those conversations about. So that was part of the welcome, was trying to focus on, hey, the rural transformation dollars are coming
Mhm.
and the opioid settlement dollars are here. And so we need to be talking about how we're going to use them, how we're going to implement them, et cetera. But also, we got bigger cuts than what we're being given. So you're supposed to celebrate for these dollars while losing
Right.
these other dollars. And so it was really kind of a dour mood in the room. But so it was interesting. I know you've been there before. So you too got to do the open welcome blessing. So you want to remember what you remembered about your welcome blessing? Because I can tell you what I got
I
out of it.
Well, I mean, I think it's good that they recognize
Yep.
on the native lands,
Yes.
and really all reflecting on the culture, of the area. I will say the burning of the sage, though, correct, Renee?
Yeah.
Not a scent that I'm a fan of, I'll be honest, and not something I'm accustomed to. So I kind
No.
of was a little nauseous actually during that part. I don't know, how did you experience the sage burning, Renee?
Yeah, it was sage, and I wish I knew what the second thing was because it was an additional because we were trying to
Okay.
bring positive energy. And
Yeah.
given the dour introduction, I get it. But yeah, most of us had headaches afterwards, and the
Yeah.
joke was made. Hopefully, we don't set off the sprinkler system. And I was like, "Oh,
Yes.
we're burning things indoors. Okay,
That
that's new, and in a contained room, so you didn't
right.
really. I want to be respectful, but we didn't really have a choice to like escape if you
They
potentially not feel well
they
during that."
he actually announced they disabled the fire systems last time because they've actually set off the fire alarms in the past when they've done these types of ceremonies to start conferences, which
Okay.
it's something you don't think about, right? Like they actually have to have the fire people come and stand by and turn
Well, I'm
off.
glad to hear that that happened.
Yeah,
Speaking of
yeah.
fires, I just told you at breakfast, the toaster oven caught on fire, like literal flames shooting out of it, and I had to go find help. And it's been a wild couple of days, Jason. It's just been really
I hope it
so.
wasn't your toast that got ruined. Was it your
No,
toast?
somebody put
Oh, okay.
cheese in a toaster oven.
Oh, that's why
Apparently
there's
that,
signs. You frequently see signs over the tops of toasters in the hotels.
yeah.
Yeah,
But
that's
I mean, the first time I've been sitting there and I was facing the all the equipment and it literally had flames and I was like, excuse me, there's flames. And so I'm like, inside a box. So I was like, well, they're contained currently, but that can't be great. So anyway, I've had a lot of smoking going on this week, which is not my thing, so just a little different. But one of the topics you and I talked about last year, we love it so much, is all the acronyms, and Arizona has taken it to a new
yes,
level. But my real
it
favorite
has.
is another first of the day is access, is what they call it. And I don't even know how they get to that name because it's AHCCCAS, which in
Mhm.
anybody's right mind doesn't spell access, but that's what we call it. And so
Yep.
that, for everyone who doesn't know, is the Arizona Healthcare Cost Containment System to care in rural Arizona. So it just
Mhm.
keeps going even past access.
It's really their Medicaid system. They just
It is
decided to name it this
something wild.
because they wanted to have all the words in it, like cost containment and all these things. Well, you can put it in the name, but if you don't do it, then it
Right.
doesn't mean anything. But yes,
No.
I love the acronyms in Arizona. It took
There,
me three-quarters of the conference before I figured out access was actually this AHCCC thing because I was thinking access.
right. And
Silly
so
me.
they actually there's a couple more we'll talk about in just a second. And then they made jokes about how we all like our acronyms. And I'm like, well, at least you
Uh,
double down. So
yeah,
I think AI is going to really help them be even more creative. And lucky for all of us, as we
yeah,
continue to go back, we may get even better ones in the future because
yeah.
it's kind of wild. So the access conversation really was about the Medicaid challenges at the federal level regarding work requirements. And work requirements, new rules
Mhm.
are coming out right about now for
Yep.
the time we're recording. And lots of people had thoughts. They were really hoping they'd get better. And it sounds like they've doubled down and made more FAQs and more specificity that gives states less wiggle room. So this could be a situation where states tried to revolt to get more flexibility, and what they got was clamped down harder because the feds are like, no, we meant it, and this is how we mean. So they're talking about a large swath of people. So this is your Medicaid expansion group. I think they say in their state it's like 500,000 people impacted. And that brings a lot of job loss, though, in addition to just people needing to have to work. There was some questions about whether or not you can clarify who has a disability and if you can have some flexibility in that. It sounds like maybe not. And so people are really, really concerned about this. And this goes live for everybody listening on January 1 of 2027. And so that's going to be a big challenge. And so the hospital CEOs and the folks in the room in the hospitals are really concerned. So I know you've worked on this in multiple states. So talk to us about that concern that's bigger than what people are saying. What are we missing here?
Well, I mean, some of this, it's so new, and I've done just a little bit of reading on it. I think the same issues we had with Medicaid and the expansion before was really who determines the level of disability. I mean, it's really not about the folks who are able-bodied. This is about folks who have legitimate disabilities that sometimes have to reattest now every year that they still have that disability. If it's a lifelong disability, I'm not sure how we're getting savings and having to have I guess some type of reevaluation. And so in many cases, that just doesn't make logical sense. I mean, we're talking about folks who have severe impairments. And so I think that's the most at risk population. I don't from what I've read initially, this doesn't help with that issue. And I think that's historically been the biggest issue, but we create these other ideas
Yeah.
of what the issue may be, but that's not where the people are, and that's not where the dollars are. So I don't know if this really changes. In some states, it's not going to change anything because they already had kind of a little more restrictive things in place. So it'll be interesting to see kind of as time goes on, as we can kind of see some of those charts across all the states of, is this just a couple of outlier states that had some really loose guidelines that this kind of brings them into line with, or is this really out of step? I don't know yet. And I haven't really read if clearly where we're at, when we think about it.
Yeah, but one of the things that they said about the rules is it's going to make them now redetermine 2 times a year.
Yeah,
So
that's
all the work
ridiculous.
they were
Yeah,
doing annually now is at every 6 months. So
right.
they doubled the workload for those
Yep,
employees and didn't pay them more to do it. And so
yep,
there's already going to be just workforce issues just out of the chute for the verification process.
right.
Um, they sound like they're going to have a pretty robust. Somebody asked the question about how are they going to
Hmm.
make sure people are notified and don't fall off.
Hmm.
They have a very robust plan. Some states, I won't name one that's a neighbor to us, basically says they're
Hmm.
going to send out one letter and that's it. And
Yeah.
so people are going to fall off simply because they
Yep.
didn't get the notification. And in some
Yep.
states, that's the intended plan is to let
Hmm.
them fall off, whereas Arizona is going to try really hard to keep them. But even their plan, you have to be able to contact people, reach people, find
Right.
people. And so it's going to be just a lot from that
And,
space.
and that's the administrative cost that's completely picked up by the state.
Yes.
So what the federal government done is has shifted all of that, and so those states who it's a really big burden on them now to do twice the work. That really increases the cost of delivering care. I've seen some of the numbers and some of the analysis a few years back. Here in Iowa, and it was going to cost way more than they were going to recoup by doing that twice a year. It made no fiscal or financial sense whatsoever to have to do that twice a year verification because there wasn't enough they were going to catch to save any money. And so really the only way to save money is to get people off of Medicaid and uncovered. And unfortunately, I think that's where you're going to see some of the states, that's how they're going to save money, but it's going to cost more in the long run because you're going to have now uncovered individuals still needing health care and care in some way. And so it's just going to cost in a different way.
Right. It's just going to shift the costs. And I
Yeah.
think they said that the work requirement is a cost shift from federal to state of about
Yeah.
$1.9 billion with a B. And that's
Yeah.
a lot of money. And so depending on the size of your state and the population, right, you get
Mhm.
the size of your chunk of that reallocation. So that becomes administrative work, like you said, on the state and not just
Yep.
things that the feds used to do. So that's a really interesting situation. I think about the time you were talking about how we're reassessing folks with severe disabilities in our own state. When I ran for office way back in the day now, the institutions were doing like IQ tests over and over again on folks
Yeah.
just to get paid as like a billing
Yeah.
mechanism. And we put the kibosh on some of that because
Hmm.
again, these weren't folks that were going to change over time. And
Right.
so why are we testing over and over again? And
Right.
so instead of doing it, the testing stuff, now we're doing this paperwork stuff and we're going to chase people
Right.
around. It's just going to be really hard. So after that conversation, we went into some breakouts, and one was called Building a Bridge. And this is an interesting concept that happens in a couple of states. I know you've looked it up since I told you about it, but I'm
Hmm.
excited because they're looking at collaborations with critical access hospitals for substance use. And it sounds like trying to get people, their medications, especially if in
Hmm.
overdose states. So what did you see when you looked at that for us, talking about that?
Yeah, that was one of those initiatives that, like, this is the good part that comes from these things, right? Of being able to get people, who want to be drug free. We'll talk in data a little bit later of why this is an issue there. Meth is a huge problem across the state of Arizona, as it is in our home state. And if we can get folks, some of those medications that keep people from using, start people down the path to recovery, bupropion. I think about all the drugs out there that we can utilize today. The issue is you need prescribers, and where do you have prescribers in rural areas and critical access hospitals? So if you can link folks with peer recovery support specialists and their medications, and support people in their home community, then you're more likely to see folks, enter the path of recovery. And so I think those are really great initiatives that we can start to combine healthcare with addiction treatment. Those have been those silos. And, we spend a lot of time in our work day to day trying to break down those silos. So I like that. I would like further integration into the entire continuum of treatment. when we think about substance abuse and critical access hospitals. But this is step one, and I would bet, and what we're seeing is a lot more integration between critical access hospitals, especially, and all types of behavioral health care, including addiction treatment.
Yeah. There's a couple other highlights, high points that I wanted to talk about. One is this, it's called H2O, which is another one of their fun acronyms, but it's about housing and health opportunities. They're trying to blend folks' housing opportunities into their wellness and as a social driver of health. Housing is a big deal. I thought it was kind
Hmm.
of fun. They had one slide to show the possible savings, but it was of one person, and it was really funny to
Yeah.
me. They said that in small print. But I was like, they were trying to say, look, if we can get this one person housed on all these costs, and they broke out lots of costs because they're
Hmm.
trying to now get data to show that if the housing happens, you save all of this money in all these other
Yeah.
areas, which anecdotally we know is true. So they're
Right.
trying in this particular program to track certain people over a period of time and figure out the cost savings, not just in healthcare, which is a big one, but in lots of other places where it
Yeah.
shows up. And so
Right.
that's another bright spot. I thought it was a cool opportunity to talk about. And the second one is whole person care in Arizona. They've been working on that one too. Also social drivers of health and putting behavioral health in that as a context, like you were just saying, more
Nice.
collaborative, trying to look at the whole person rather than just piecing off the different pieces. And as the
Hmm.
budget gets cut, that's exactly what's going to happen. We're going to have to like do those
Yep.
things kind of more as a group. So had you heard of those two projects last time when you were there?
I don't think so. No, those both sound really good. I really like. I kind of like the H2O thing. So did they use the metaphor? Everyone needs housing, just like everyone needs water. Did they
Pretty
do any of
much.
that? Is
Pretty
that pretty much what that
Pretty
was?
much.
Yeah. See, I
Pretty
got it.
much. So they've got it. And so yeah, so it's it's easy acronym to remember. And so, yeah, it's really neat to talk about the social drivers of health. So they really got it. And I know you and I talk about that all the time in our
Hmm.
presentation. So for them, I, saw it before we got there. So when I could speak about it, I would say, as you saw in the keynote a while
Right.
ago about this is how this piece plays in. And so it makes it make more sense to everybody in the room because they're really trying to do whole person care because Arizona figured out that the top spenders in their healthcare come across all kinds of groups, and they
Yes.
really do. And I'm glad we were there because nobody really talked about the incarcerated side much of this,
Mm,
except in the access conversation at the beginning. They're looking at their 19 or their 1115 waiver. A lot of those Medicaid waivers now, you can get people their
mhm,
benefits before they leave the incarcerated setting, or maybe just put them on hold instead of dropping them off and then
mhm.
depending how long they're in jail. And so they're in that same conversation, just like we are in Iowa, about how
Yeah.
do we get people on those services earlier. And so that in that setting, they talk about it, but then the rest of the whole person, not so much. So there's still some gaps in the conversation about, hey, there's a lot of people in jail for the wrong reason,
Yep.
and how do we help them?
Yep.
One more crazy acronym for you. It's the Southwest Cacti. This is the Southwest Center for Advancing Clinical and Transformational Innovation. I think they've been spending too much time with AI, but their cute little cacti logo, it was adorable. And basically, what they're working on is trying to gain, again, more information, tracking better data, understanding what actually is moving the needle in healthcare costs and things, and trying to get a little more information about what we can do to change healthcare. And the change being more from sick care to preventative upstream care. Like,
Yeah.
how do we keep people well and turn it into wellness care instead of just the sick care? And there's a big conversation happening about how our healthcare system is focuses on those who are sick, and that's what costs so much. And we're really not doing a lot of the stuff on the front end. So they had Secretary Kennedy over the lunch hour with a couple of videos about talking about his Make America Healthier Again initiative. And whether or not you like him or not, that isn't the point. The point is he's on the right track about some of the stuff that we've just allowed in our food and in our water and in our air and things that our country has allowed. And so we're, higher levels of cancer rates, as an example, higher levels of chronic illness, higher levels of obesity in children, higher levels of lots of things that correlate with shorter lifespan in America than other industrialized countries. And so he's really trying to change up that conversation. And so
Mhm.
there's a lot of conversation about, how do you do that? And so, like in our state, we're one of the top in the country for cancer. So they're starting to look
Yep.
at what are we going to do about that? And how are we going to address that issue? What's causing this issue? All those kind of things. Same kind of conversations going on in Arizona and other places. Do you have any thoughts on Senator
Well,
Kennedy?
it sounds like you got a lot out of this conference, Renee. I mean, I think it's great to hear all the things happening in rural,
Yeah,
I think that's the main element for us is like, how do we take these things, but take them beyond a pilot or idea to actually be consistent across large spans of rural areas. And I think that's the really hard part of going to these
right,
conferences is because we always hear these promising practices or these little gold nuggets of innovation in one place, but how do we help states or how do we get, entire areas or regions, districts, whatever it is, to be more consistent so it's not a big map of haves and have nots.
right. And it's always good to be in a rural setting like that where they bring in the national picture
Yeah.
so that, have some folks explain it. And again, these folks are also our big advocates too. They're like their association's advocates. And so they're telling you what they're trying to. So there was lots of slides on here's what we're doing about this piece that we know you guys don't
Hmm.
like. These are public input sessions available to you to talk about it. So they're like that go-between the federal government and what's going
Hmm.
on locally. And so it was really good to see both sides because they have to explain what's happening at the national level so that you know what to comment
Right.
on, right, as a person in the role. So it was
Right.
really good, and we learned a lot of stuff. So moving into data, I learned some not so good information. So
Yeah.
yeah, Arizona is the top in the country for the number of deaths due to overdose for increasing numbers of overdoses. The change for more people dying due to overdose, they were number one. There were five states in the nation that went up over the period of time from September 24 to 25, and Iowa is one of those five. It's Iowa, North Dakota, Colorado, New Mexico, and Arizona. And Arizona was the highest. And that is related to use of meth, amphetamines. And in Arizona, what was really interesting, they have two different lines that go off the chart. One is meth with stimulants, and one is without. Doesn't matter, they're killing people both ways,
Hmm.
but they've got two
Right.
different types of meth that are killing people. And so there's lots and lots of work being done on getting all the life-saving treatments that are available and making sure that you're trained. They have now where you can get like a little bag that has your products in it so that you can save somebody's life with little cards that you can
Hmm.
get specific help back to your region for like if you've got the little bag and it's really pretty innovative and they were giving them away for free that basically it has a little card inside that if you have to save someone's life hit this QR code it'll tell you exactly who to call to help that person in your area so they're trying to get people like real-time help because the data is so terrible so I was thinking about that and I grabbed one of those little recycle bags it's not going to really help me
Hmm.
myself but that's some things we should be doing in other states is finding
Hmm.
people that can help make sure people know who to call in case of an
Yeah.
overdose because you can get them the life-saving medication, but then you need the next thing. And so they're trying to make sure that people are educated on, now that you've helped somebody do this next, and this is who you call in your part of the state or your part of the region, which I found is kind of
Right.
interesting. But the data is not good. And so that's one. Did you have any thoughts on that? I know you guys we haven't really, that's a slide we need to see if we could figure out and put into our deck about Iowa because
I,
it's going up, but we don't talk about it as much as we should, I don't think.
Well, I'm just interested, I'm looking at that map and I just haven't seen it represented this way, but it's really those Midwestern rural states are all
Yeah,
higher, right? Well, you talked about the highest rate, but the rest of the other states surrounding those states are also very high,
yeah.
in concern as comparable to other states with higher population or more density of population. You know, I think about the work we do in Iowa and Colorado right now. Those are two of those five states,
Hmm.
where we already are, and I know in some of those other states that the data may be skewed more because there are large population centers that may use different substances. The rural areas of those states are still, I know high. I think about being in Southern Illinois every month. We hear a lot about what's going on there and the issues as well. So yeah, I'm intrigued by this, and I think we need to kind of sort through: is this an access issue? Is this because we don't have enough providers? What's really happening there? So this data is really important that we look at it and have
Yeah.
conversations around it. So I really appreciate you sending that slide on.
Yep, and one of the states is where you're sitting today. You also had North
Yeah,
Dakota, and
that's
so it's one
exactly
that
right.
you these are ones that we've worked in, we've spoken in, we travel to, and so we work in this. So we need to figure out. But they again, go back to Arizona. Yeah, they got wild acronyms, but they've got these amazing dashboards. We talked about that the last time we did
Yeah.
this. And so they can pull out data from this time to that time and show different
Mhm.
pictures, which we have not always had that ability. So sometimes we don't get the on-time data that we would like to have in our state, but that's
Yep.
why Arizona has this. They've really dove into that technology and making sure that they put in a lot of information. So you can get out all kinds of interesting things.
I was just thinking, ironically, the two of us have been to four of the five of these states in the last week, Renee. So,
And I was just in New Mexico last month, so
oh,
this makes
there
it
you go. I
all
think
the
that
way
says
around.
something.
I know, and I didn't use meth one time in all 5 states.
Well,
I just want you to
good,
know.
good for you. That's
I
good.
know.
That's
I didn't
nice
run
to
into the
know.
guy at the bus stop that sells it. I hear that's a thing.
Yeah,
So I
yeah,
didn't run into
yeah.
that guy. The other data we wanted to talk about was incarceration rates. And this is another piece of data that we always talk about. And Jason puts
Mhm.
it into our deck and always blows people away because they don't think about incarceration very often related to behavioral health and
Yeah,
rural health, but they need to because that's the alternative location they go to. When
right.
you go to an emergency department and you don't get the help you need, the other option is jail. And so they're spending their taxpayer dollars on this, whether they think about it or not, because we're at a rural health conference. They're not thinking public safety, they're not thinking all that stuff. And so every time we put these slides up, it just blows people's minds. And so one of the laws that we point out here in this state is pre-trial. And I had a good time in my conversation in the presentation talking about how they're putting people in jail before they're convicted. Like the slides on the wall, I'm
Mhm.
like, this is pre-trial, folks. I'm like, you're just saying because they were accused of something that they're going to go sit in jail and look at the numbers. And the people were like appalled in the room. And I'm like, this is available to you. The data is available to you. And I always like that we source and cite where we get
Mhm.
our information because people
Mhm.
are like, oh my gosh, what's that? And like, you can see when you guys changed the law. And this is pre-trial. And they said, so these are the folks with mental health issues. And then we go on to talk about, who the number of people percentage wise that have mental health or substance use versus
Right.
that don't in each incarcerated setting. It's a real eye opener for folks. And so they always appreciate that conversation and are interested in, what we can do. So we always talk about telehealth being one of the pieces. They
Yep.
think of telehealth in an ED and I'm like, we use telehealth in jail. You can use telehealth in reentry. There's no reason in the world the person comes out of prison and has to wait 6 months, 8 months, however long to get to a psychiatrist and fall off their meds. Telehealth is available for that interim until they can get an appointment in community. And so helping people kind of talk through that was with this data was really important. And just like every time you talk about it, you got a bunch of ahas in the
Yeah.
room, just like they had no idea. And so it was a really good, and they're not part of any collaboration, to be fair, that's even
Right.
happening. They're not talking to the sheriff who's mad about dropping people off.
Hmm.
They're not talking to the third shift people that have to deal with it in the ED. They're not talking about all those people who are not, that are going to quit because they're just over it.
Yep.
The overworked ED doctor or nurse who's by
Yep.
themselves. They're just not having those conversations. So that's why it's always important to talk about it. I know you do a lot of conversation about collaboration related to that all the time.
Huh. Yeah, we do, and I mean it's almost exhausting, Renee, because it's come to a point in some states. It's literally county by county. We have to have these conversations because there's a lack of a unified state vision as to how do we really address this issues, this constant, you know, it's just this constant hamster wheel, from ED to jail, with police just in the center of all of it. And it's very rare that we would see a natural conversation occur between the ED, the behavioral health, or the CCBHC provider, the mobile crisis provider, and law enforcement and the jailer. And so it's really, how do we include all those people? And the jailer is actually one of the key components of this. He's the
Yeah.
person, or they are the person, she's maybe the person. They know every individual who's cycling in and out of jail and their diagnosis.
Right.
And in a smaller county, it's that local jailer who actually has a better pulse on where someone's at in their disease as to when they're cycling or when they're psychotic, because they see them in jail on a regular frequency sometimes, and if they do a better job probably of predicting when someone's going to come back, or fall off their meds, or when a script is due, than anyone else.
Yeah.
And we don't always take that into consideration.
No. Well, today, everybody, I'm going to go dive right into the recovering politician self-care policy of the week. When I'm traveling and I have a very short travel window and I'm flipping multiple time zones, I stay on my home time zone for the whole trip. So for me, I'm 2 hours different than I was, and I'm only here for 2 days, 3 days with travel, and I have to go back to work tomorrow, and I go back to my regular schedule. So for me, it didn't make sense to try to sleep at the time of here when I'm 2 hours different going back home. So I've been up super early, which is kind of annoying, but at the same time, it's like if I'm not, and then I'm really off. So I was at breakfast at like I don't even know. And here this time was really early, but it's like normal time back home. And so I found yesterday found a Denny's for breakfast early in the morning. And I was like, I'm just going to walk across the street. They're open 24 hours. So I could have it crack of dawn all by myself. But I had to stay on schedule because otherwise for me, I just don't. But it helps me. I don't get jet lag that way if I stay on the same schedule. They have great blackout curtains. I just take a nap, go to sleep the same way. I don't know about you because now you've been in multiple different time zones. I don't even know how you know where you are most of the
I
time.
don't. I don't. And it's kind of scary. Sometimes we're like, what time is it and where are we?
Right.
That's become a more regular conversation. But yeah, staying on routine is just essential. And my internal body clock, I just wake up at this I like 6 a.m. Central Time. I wake
Yeah,
up.
me too.
So the other day I found myself up at 5 a.m. And I'm like, well, I guess I just will get up, right? Because staying on schedule is essential. Probably the worst is eating, though. Rural areas, and Renee, you know this. We fly into somewhere at 8:30 at night.
Yep.
Especially if we fly into Steamboat or Hayden, in Steamboat Springs in Colorado. There's nothing open. There are not restaurants, or
Nope.
you have to travel half an hour, and then you've got Taco Bell, or the
Right.
choices, and that it goes back to rural health, that you don't have healthy choices in some of these places. It's fast food, or it's things that I really try to avoid when I'm traveling, and so that's probably the bigger challenge. Is sometimes just because of the way schedules work out, maintaining healthy habits that can
Agreed.
be really tough. And this is petty, but working out is really hard for me on the road. And part of it is I just take a backpack everywhere I go because check baggage, everything is so expensive. So I just have one pair of shoes. So sometimes I'm just wearing dress shoes, and that's the hardest thing, is having the stuff with you
Agreed.
and then carving out the time, because sometimes
Yep.
I'm up having called, right? Just like you are today. It's early there. It's mid morning here. I got to go to the conference right after we get done with this. It's just hard to juggle it all.
I agree. Well, everybody, today we talked about the Arizona Rural Health Conference, and we've been on the road and we're in two different states doing our work in rural communities all over the place.
Mhm.
Hopefully you got some entertainment out of today's conversation, and we didn't burn anything down, but we could have. And we talked a whole lot about what's going on at the federal level with Medicaid, which is scary for everyone. And then some collaborative ideas of things that are working, some hero programs, if you will, that you might want to check out and look into. We'll put some notes in the show notes so you can check it out. Next time, we'll see you then. Bye, everybody.